first a review of the design of our impact evaluation that has been evolving, and some details are still getting defined. An outline of the completed and future activities related to this impact evaluation, and then also an overview of the baseline data we collected and some selected findings. And then this activity, this RFSA, Okhokelamo Ni Solha, is a 5-year RFSA launched in 2022, led by Save the Children, operates in about 400 communities in Zambezia in Mozambique. The goal is to sustainably improve nutrition outcomes for children under 2, pregnant women, adolescent girls in 4 districts of the Zambezia province. And kind of the 3 buckets of the interventions is food distribution is a core component for eligible households, which are those with children under 2, pregnant lactating women, or adolescent girls, at least in some of the seasons. And then social behavioral change for a broader set of those households, but also the broader community. And then a productive cash transfer for food eligible households. I'm going to refer to that as cash plus in the rest of the presentation just for brevity. And to motivate this impact evaluation, just briefly, we start with limited high-quality evidence on the RFSA's overall impact and cost effectiveness. We, not on this RFSAs, on RFSAs in general. And then to optimize programming, we would like to identify the impact of specific components, which will then allow us to design programs that are more effective in the future. And then one in particular here is this Cash Plus intervention, which is being introduced to RFSAs. And then Cash Plus, broadly conceived as, productive cash transfers with and without training, or graduation style programs with lots of training around it, have been successful in other contexts, and there's lots of broader evidence-based, but there's limited evidence within the context of the BHA RFSAs. So then one question we'd like to answer is the impact on these RFSAs on household economic activity and their relative cost effectiveness. From this motivation leads us to 2 core evaluation questions. First is, what's the impact of Okhokelamo on well-being and nutritional status of food distribution eligible households? And then the second one, for food distribution eligible households, what is the additional impact of participating in the Cash Plus intervention above and beyond the regular OCO programming on household economic activity, well-being, and children nutritional status? And for the design, I should say 1 of 2. We have 2 stages of randomization. Stage 1 is completed. That's the randomization of communities into treatment and control within study locations. And then just briefly go over that, how that works, or how that works. So treatment here means targeted by the RFSA, and control means no implementation by the RFSA. And before this assignment, we selected 4 study localities in 2 districts. These localities were sampled proportional to the population with the goal of containing a sufficient number of we call non-excluded and non-must-serve communities for the study. I'll go over what each of those mean in a second. And then the number of study localities, which is only 4, is localidades, reflects trade-offs and between resources and statistical precision. 4 is a limited number to recognize. So while they are drawn randomly in proportion to the population, they are in principle representative of the larger area of the 4 districts that they're drawn from. Because they're only 4, the ability to to make conclusions about the broader area is somewhat limited. And the advantage is that we have more precision for our study in sort of a narrow sense, but also in a logistical sense, based on past experience with the wide distribution. We try to, in this case, limit the study to a very specific area in order to maximize the chances of implementation in compliance with the design. And then within the study localidades, 50% of the study eligible communities were randomly assigned to treatment. I'm not going to go over this whole chart, but just to briefly, there's a flow chart here that describes the sampling and the randomization. So there's an eligible pool of about 1,000 communities across the 4 districts. Then some of them were excluded from implementation because the urban or sort of don't fit the targeting criteria of Okhokelamo, or some of them are even, I think, unreachable. And then within the eligible pool, there's some that were tagged as must serve. And so this is the solution we came up with together with SAVE and Okhokelamo team, which we've have a very cooperative relationship with to try to resolve any kind of challenges designing the impact evaluation within the larger RFSA, and the solution here to the challenge that some communities need to be targeted for sure is to set them aside as must serve, which is only a limited number of those, as you can see, and then work for the study with the remaining with the majority of those remaining ones. And see now that 588 doesn't add up to 1,000 with 95, because I think the 317, there should be another arm here. And then we sampled the 4 study localities from, in principle, 4 districts. They ended up being only in 2 districts just by the way the randomization shook out. And then we randomized into treatment control. And then within those same study localities, there are some communities that are non-study, for the reason we explained above. And in addition, some were found to not exist after we did the scoping exercise before we did the actual randomization. So this was the first stage of the design for the, and then there's a second stage that's still outstanding, we're working towards, is a cash plus lottery within the treatment communities only. And for that, the randomization will be carried out as a public lottery by the implementer in cooperation in general with us, but the OCO teams are going to be the primary implementer of this lottery. And this lottery was, in this case at least, scheduled to happen anyway. It happens across the entire RFSA implementation area. And then we're going to make use of that in our study communities by using this random variation for our study. Households take part in the lottery if they're food distribution eligible. And then 20% of the participants will be chosen for participation, the winners of the lottery. And that's the variation we're going to use to study this cash plus aspect. And now, based on this design and based on our research question, we have 2 comparisons we're going to make. Call this one the comparison A, which is the RFSA without the cash plus programming versus no programming. So that's designed to answer the evaluation question 1. Compare the households between treatment and control communities. But in treatment communities, the comparison to controls will only be those who are not in cash plus, which subject to being on the lottery list in the first place was random. And that gets us the overall effect of OCO without cash on this comparison A study households, which I'll not go into too much detail, but the idea is that for this comparison, we can focus on certain subpopulations specifically because there's a large number of people in the treatment and control communities, and the comparisons we're making will generally be different from the comparisons from the types of households that will be in comparison B. There'll be overlap, but they'll not generally be the same. And so for comparison B, then we have the lottery lists households without cash versus the cash households with the winners versus the losers of the lottery. They're going to be in our we're going to be targeted by our surveys, and we're going to be comparing those two to measure this additional effect of cash plus on top of other Okhokelamo programming. Again, on the comparison B study households, which overlap with the comparison A households, but are not generally identical. And this is a flowchart here, again, not to go through all the details, but we start with 147 IPA study clusters. These are the communities within the 4 study localities. Roughly half treatment control. In the control communities, there's food eligible households and non-eligible households. We're going to be surveying the food eligible households. Preliminary sample sizes here with 1,300 households, and then we're going to go to the treatment clusters where there's again food eligible and not food eligible households. Among the food eligible households, as identified in our upcoming census, there will be households who are not on the lottery list because of a mismatch of various sorts. We anticipate those being few, but those will be included in the study. And then households on the lottery list, there'll be those randomized in and out of cash. And then here the yellow groups, the 2 yellow groups in the treatment clusters will be combined into an average, and we compare that average. That's the households in treatment clusters that did not receive cash plus and that are in general comparable to the control clusters here, the food eligible ones. They're the same types of households. The only difference between them is that some happen to reside in the treatment clusters and others happen to be in the control clusters. And for this comparison B, we zoom into the treatment clusters. We look at the food eligible households. Again, we have the ones who are not on the list. We'll ignore those, and then we'll look at the ones who are on the lottery list, and then some are randomized in and some are randomized out, and that's the comparison we'll be using for that second evaluation question. And again, this is a lottery that's happening across the entire RFSA, and we're going to just make use of this opportunity of this randomization to 20% of the households in our study communities to separate the effects of the overall program from that of the cash plus component in particular. This is sort of a broad list of the steps of the impact evaluation. We did a scoping exercise, or rather Fulvia did, on the ground to identify the study communities, collect basic characteristics. This was ahead of the randomization. That was last year, at the end of second half of last year, and then at the end of last year, worked together with a OCO team to randomize households into treatment and control. And then in March, April after that, shortly after the start of the introduction of the activity into communities, we did a limited scope baseline survey with the goal of producing summary statistics and provide information about the context. And then next up is early next year, we're preparing for right now is a census to create the sampling frame for this for the future follow-up serving of the different types of households that are going to be in the study. After the census, we'll try to do our best to cross-reference the census with a list of OCO participants, in particular the food distribution participants from this second season, in order to have clean groups of households that are on the lottery list, not on the lottery list, and then once the lottery happens, we'll have among the households who are on the lottery list, those who are drawn to participate in Cash Plus and those who won't. And then in the future, not next year, there'll be a follow-up survey work based on this sampling frame that we're creating now with the census. Okay, so now to the baseline. The purpose was some limited scope data collection to describe the target sample for the study and report on the BHA indicators. The purpose was not to interview everybody who will be in the follow-up samples. So there's a separate part. Some of them may be, and we'll use that information, but in general, it was smaller and it's designed somewhat independently of the sampling for the follow-up data collection. The reason is that twofold. First, the design, all the details of the design were not fully finalized by the time this baseline needed to take place. Given uncertainties around the program and given the timeline of activities on the ground. And the second reason was that to some extent, the households that are most interesting from the perspective of the evaluation were not identifiable at that point in time. So specifically, we would like to follow up with households that have small children or pregnant women in the time period that the food distributions take place, or that are most affected, most exposed to the food distribution by the activity. And who those households are is not necessarily known, or not in general known, before the program starts, because many of those children will still be born. Some of the women will not yet be pregnant, yet we want them to be in our follow-up survey sample. So that those are the reasons why the samples were somewhat independently designed and do not in general overlap. And the focus for this baseline was on the children, households with children under 2 and or pregnant or lactating women. That is the group where we expect the highest impact on childhood nutrition, given the focus of the food distribution. That's the focus of the impact evaluation in general. And so that was the targeting criteria for this baseline as well. And then what we did in particular, we randomly sampled 25 communities from the 4 study localities. We did a census, worked with the local survey firm to list a total of over 1,000 households, from which then we could identify and sample the types of households to be interviewed for the baseline. Ended up with 22 households with a target of 22 households that meet the target criteria per community, for a final number of 550 roughly interviewed households. And then we collected a number of indicators. We'll obviously not have time to go through all of them, but they're in general available in the report on children's health, women's health, food security, WASH, agriculture, gender. And then before we jump into some of the findings or summary stats from that baseline, just to note that the baseline statistics are based on a sample that is representative for the population of the households targeted with the survey that reside in the types of locations selected for the study. And as I mentioned earlier, since the number of locations is limited, only 4 localidades, relatively concentrated area, while they are drawn randomly and therefore representative of the larger area, the limited number of them does limit the applicability beyond the specific sample. And I mentioned the trade-offs in making that choice about the design. But just to keep that in mind. So first, get a rough sense of the household demographics, the household size, about 5.5 members, vast majority is male-headed, relatively young population at 34 years on average for the household head. Most are married, and education is low. You see that we have this on the right. The graph shows the share of households with children in different age categories. And then again, to remember, we targeted households with young children under 2. But you see that many of these households also have older children, and so we can provide statistics for those older kids, but the targeting was based on these younger children. Okay, and then what are we seeing in the numbers? First, on nutritional status, that small children generally do not receive a minimum acceptable diet. Less than a quarter consume a minimally diverse diet. Most children do see early initiation of breastfeeding, but only half of children are exclusively breastfed. Most infants do transition to solid, semi-solid, or soft foods around half year of age. And then about a third of children under 5 in our sample had diarrhea in the past 2 weeks, and among those 2/3, so the majority does get treated with oral rehydration salts. And then moving on to anthropometric indicators. In the baseline sample, we had 737 children under 5, and the stunting rate was 34%, and the wasting rate was 13%. The rates are slightly different from the figures in the DHS, in the most recent DHS from Zambezia province, where the stunting rate was higher and the wasting rate was lower. And to explain that difference, first, as we've mentioned, the baseline is representative of the households that are in the areas targeted by the study. And in particular, children under 2 are less likely to be stunted and more likely to be wasted, and those are overrepresented in our study sample by design. RFSA on average targets poorer communities. And then the baseline took place at the end of the lean season, which could possibly lead to a high incidence of wasting than the yearly average represented in the DHS. If we look into that in a little bit more detail, I see there's a question there. Let me just wrap up this slide, and then I think we're done with the nutritional status, and we can answer questions. We have this 34% figure from on the left here for stunting for children under 2 in the baseline. If we split it up by children under 2 and children 2 to 5 years old, you see that the children 2 to 5 have a much higher rate. And the fact that these children are, due to the design of the targeting for the baseline survey, are underrepresented, means that a sample that was drawn representatively would have been closer to the DHS Zambezia. Again, not to say that the numbers have to be identical. We have different Okhokelamo targets certain communities. There's sampling error in the first place, but this would be one explanation why the average for the children under 5, the standard population for this indicator is lower than the one for Zambezi on average. And then we have a similar pattern, less strong, less stark for the for wasting, where again the incidence of wasting is somewhat lower among the older children, which makes it closer to the DHS Zambezi average. Okay, maybe let me stop there. I see there's a question in the Q&A. Do you take into account different districts, and different districts are quite different with respect to agroecology? Have these results influenced implementation plans of how? Okay, is this Mara Mordini? Doesn't say. So on the first question, Brian Hilton, my answer would be this baseline survey and the study more broadly is designed to test these questions on a specific set of districts, a specific set of locations. Those locations were drawn representatively, but from the 4 districts, they end up being in 2 districts only because of the limited number. And more broadly, the decision was made we made the decision jointly with everyone else to focus the study on a smaller geographic area in order to increase the compliance with the study and increase precision, trading off the larger cost that you have if you draw a survey that's representative of a larger area which comes with fewer lower sample sizes to make up for that higher cost of traveling. And so that means that the study, and including the baseline here, is representative of those study areas, so those districts, and in particular those 4 study locations, more than being representative of larger areas where the study is not taking place. Whether they have influenced implementation plan, this would be for BHA or SAVE. And then Ryan Hunter here, just to make sure I'm clear, households were selected participate in the survey because they're PLW children under 5, but the information is saying that it measuring chronic wasting for children under 5. This is because you measured those if they happen to be in the household. Yeah, so that is correct. Is the answer is yes to the question from Brian Hunter. Okay, does anybody want to come off of mute to ask more questions, or should I move on?
I like my question explored, Lassa, but it can also, I kind of put it there just to make sure that it gets answered. We can wait towards the end of the presentation to hear from Save the Children. Over.
Okay, great. Let me jump to the next part here, which is women's health nutritional status. We see a limited prevalence of underweight status for women of reproductive age, broadly in line with the figures from the DHS, so a little bit higher than Zambezi on average and higher than rural Mozambique. But we also have some confidence about, so they're different, they're slightly higher, but maybe that depends on the implementer or subject matter experts on this, I think, but they're not on a different scale. And then women of reproductive age having a minimum diverse diet is significantly higher. Only a quarter have diet of minimum diversity, which of course is far from 100%, but it is higher than the 15% on average from the most recent DHS for rural Mozambique. Okay, food security, 40% of households are classified as having poor food consumption according to the food consumption score. Only 25% have an acceptable food consumption score, in line with the general expectations about the poverty of households. And then we have a number of indicators that were collected on WASH. A vast majority does not use any method to treat water, and only 6% use one of the recommended methods. 37 practice open defecation, which is far from zero, so it's non-zero. It's one of the things I think that is on the list of things that Oko wants to address in social behavior change, but I would note here that it is, while it is similar to the most recent DHS, the figures, it is lower than earlier numbers of the DHS and some of the numbers cited in the original application, reflecting the time trend that's taking place, irrespective of any intervention. And it's one of those things where you're going to be at a disadvantage on drawing solid conclusions from a before-after comparison if the general trend is downward, and you want to attribute the effects of the program to changes over time. Only 30% use basic sanitation services, which is measured lower than the numbers in the DHS. And so in that sense, worse maybe than expected potentially. And then we have the HY's water security, insecurity experience aggregate indicator. Only 6% are water insecure, which, again, I'm not an expert on water security or WASH more broadly, but this number seems low relative to other things being terrible, and then this is only 6%. But if you look at the types of questions that are answered, whether people worry of not having enough water, or these various problems about how this indicator is measured, and sort of close to 90% reports and never having any of these problems or complaints related to their water. That doesn't mean that the water situation can't be great. We saw that on the cleanliness of water, but maybe given the expectations that people have when they ask these questions, this is how they answer this set of questions. And I have a number of gender indicators here. More men than women earn cash in the past 12 months. Of the women in union with children under 2, but half made decisions about child health nutrition jointly with their partner, as well as decisions about household resource management. Less than half participated in decisions about the use of self-earned cash, which, as you can see, the sample sizes become very small due to the fact that only a few individuals fall into this category who ask these questions. So it's the women who earn cash is a small subset, and it's a limited scope survey, so the sample sizes are small for these indicators. And there's very limited access to credit, as we know from this. It's typical for this context, for women or men. Okay, and with that, I can summarize that we're conducting an impact evaluation of the Okhokelamo RFSA, which is designed to test the overall impact on key outcomes, as well as the additional impact of the Cash Plus intervention in particular. The RFSA is underway. It's approaching a second season of food distribution. The initial IPA survey work has been completed, and then the upcoming steps for us are this next steps are the census that we're preparing for right now, and then the lottery is taking place in the first half of next year. That will determine the participants in the Cash Plus interventions. Thank you. Then for questions, we have Mara's questions to start out with, and if there's any other questions, happy to give it a shot.
Thank you very much, Lasse. Yeah, please do feel free to come off mute, raise your hand, and pose your question yourself. If you'd rather enter it in writing, just use that Q&A function. While we're waiting maybe for some questions to come up, I don't know if this is something, Brian or others, if you're able to respond to it all. Mara's question about how some of these baseline findings may inform your implementation plan.
Yeah, maybe I could say that for the most part it will not. We had a little bit of surprise on some of the anthropometrics, so that high wasting was a surprise to us, and when we're comparing with the DHS. And initially, the numbers that we saw from this baseline were lower chronic and higher wasting, but I think that then we have those explanations. I'm not sure that changes our design at all. I would say in general, anything that we're seeing in the baseline doesn't change our design. The negotiation with how, as Lassie was showing how this was designed with all of the randomization, I think that took a little bit of time, right, up front as we were going through that refinement year and doing some pretty significant changes to the program, adding components. Lassie didn't talk about this, but the WASH is also now a pretty large component of the program, and it wasn't to begin with. So I think it was some of the delay in getting our redesign approved, but that doesn't necessarily have to do with either the results, the carrying out the baseline, or the results of the baseline. So I think in short, the question is no, it doesn't influence our program at this stage. Over.
Okay, thanks for that explanation. I do know.
Can I ask just a follow-up question, Tom?
Important. Yes, of course, Mara, go ahead. I'm just noting that the anthropometric question is important given it's related to OCO's performance targets in terms of a reduction of malnutrition. So yes, please go ahead and pose your question, Mara.
Yeah, I just wanted to get some clarification, and maybe, Lhasa, maybe you can also help here. But Brian, I think, if the wasting this was a very localized baseline survey. And so I guess what I'm wondering is if these findings are, higher generally across the board, higher or lower than what you guys had put in your application, or what your formative research is showing for the entire OCO area, would these results, which is done at a very specific area, warrant like an increased focus on any particular intervention, or the opposite? Like, okay, we don't need to so intensively invest resources or time on this particular intervention because the indicator is already trending in the right direction or high enough that we should direct resources to an area that is underperforming. So, recognizing that these results may not be applicable across the entire OCO area, what about in the areas where the baseline is done? So you're saying that these findings aren't going to influence the rate of implementation at all, or just not broadly? Over.
Yeah, certainly. We can look at, we'll be paying special attention to, why we would have seen those spikes. But it definitely, as Lassie says, these are what four localities of the entire area. So this is Makup. These are in two of the districts, and they're kind of geographically similar. So we have a whole nother region, the two other districts that these results would not be applicable for. So I would say, in short, the question the answer is, it doesn't influence our overall program. But we will look more into the nuances of what we found in this study has shown in specific areas, particularly that high wasting, to see what's happening in this sort of the lean season? And is the timing of that lean season distribution correct? When does the lean season start? I think those would be things that we would look at, but more locally to the area in which the survey was taken out. Again, not applicable necessarily, or doesn't change our overall programming across 4 districts. Over.
Thank you very much, Brian, for that response. Mara, I hope that answers your question. Lassa, feel free to follow up on that point if you'd like. In the meantime, we have another question posed by Wilbert Quintanilla, who's also looking at some of the WASH results, and he's curious who was asked the water insecurity questions, and was it the person responsible for fetching or collecting water? It's surprising, as you pointed out, Lassa, that only 6% of respondents felt water insecure given limited access to water resources. So again, who was asked those water insecurity questions, I think, is what Wilbert would like to know.
Yeah, that is a good question. I don't have the answer right now. I somewhat assuming the household head, but I have other team members who might been closer to the implementation, the baseline on this call, who can answer this. If not, we'll have to follow up. I would say that, you know, if it is the household head, I don't know if what was designed, you know, this is how that person answers the question, so that is interesting in itself. But it's a good point that maybe the person who is doing the fetching water feels differently. But I don't know if Antoine, you know, without looking it up. I don't.
I would also say the head of household, but I could look at it and get back to the team.
According to the handbook, now, you know, sometimes the surveys end up, sorry for the dog in the background. The surveys end up being tweaked a little bit for various reasons, but according to BHA standard approach, it's a responsible adult in the household. So it very well could have been the head of household if that was the individual available to respond.
Thank you, Mara.
Hi, this is
Any other questions?
Thank you for that. I just
Sorry.
wanted to bring up that, you know, like I think Lasso already mentioned it, that, you know, I think that the person responding, if they're not the one responsible for fetching water and water is available, they're not going to feel water insecure. They won't know how long it takes to get water. So I think that we probably need to really think through how we would collect this data moving forward, because the 6% doesn't really match what we've seen in the, you know, like when we visited communities, but also it doesn't match what we saw when we did our formative research. So yeah, I just thought that was it would be interesting to know if we could figure out who's responded to this question, so that we know in the future moving forward, maybe we would ask who's responsible for fetching water and ask the questions to them.
Thank you, Wilbert. Any other questions?
Actually, can you go back to the water or the wash section? There was something on open defecation that I wanted to ask. What does you mean? Okay, so at the second bullet point, towards the end of that, it says that is lower than the Okhokelamo application.
Yeah, so originally, actually, I had written then the 2018 DHS, because that's how it was written in the technical documents we have from Okhokelamo. But then I realized that according to our records, 2018 DHS didn't collect this information when we went to look it up. And so I just changed it to the application that
Okay.
because
So we cited
it must have been
56%.
Yeah, exactly. So it must have been a typo.
Okay.
The source must have been a typo, but the broader point was to just to highlight, if this is supposed to be useful in changing priors, right, then it is in line with the priors of the 2023 DHS, which just came out, right? So it's very recent, which wasn't available, I think, at the time of the design. But, to the extent that this is updated information relative to the state of knowledge at the time of the design and application, this is lower. So I just wanted to highlight that in case that's useful.
Okay, thank you.
Thank you, Lhasa. Any other questions while we still have time? Please don't be shy. Feel free to pose a question yourself or put them in the Q&A. Okay, well, while we're waiting, I'll just say if there are no more questions forthcoming, let me say thank you first to you, Lhasa, and to the entire IPA team for not only carrying out this work, but for sharing the baseline findings, some of the findings, and explaining the methodology. It's been quite helpful. Any final questions before we drop for today? Okay, we'll give everyone a few minutes back then. We very much appreciate your participation today, and have a good rest of your day. Thank you.
Thank you, everyone.
Thanks, everybody.
Thank you.
Thank
Thanks, all.
you.
Thanks all.